Thank you very much. Good morning, everybody. So my name is Dr. Francesca Conradi, and I'm going to be talking about the treatment and prevention of drug-resistant TB in people living with HIV. Just like the two previous speakers, we're talking about a condition that can affect people who are living with TB and who are living with HIV and those who are not. And what I want to bring out in this particular talk is what is the difference in those who are HIV infected. So the topics that I'm going to be covered is, first of all, is how big is this problem of drug-resistant TB? Is it small or is it big? I'm going to do a little bit of housekeeping and talk about the new definitions of drug-resistant TB, and then spend the vast majority of my time talking about the current recommendations from the WHO for the treatment of drug-resistant TB and what we can do to potentially prevent it. As we all know that from the time an individual becomes infected with HIV, they are at a higher risk of the development of active TB disease. And that starts pretty much in the first year of infection, and it increases for the duration of their infection until they are initiated on antiretroviral therapy. And I guess that this is a good place to put it, that one of the best ways of preventing drug-resistant TB or any TB in an HIV-infected individual is the initiation of antiretroviral therapy. So let's have a look at where TB occurs, and in particular where drug-resistant TB occurs, and look for where we're going to see overlaps. On this slide, and these comes from the latest WHO reports, on the side on the picture on the left-hand side, we can see that TB occurs mainly in sub-Saharan Africa and Southeast Asia. And then when we look at the kind of pink blobs on the other side, we can see that there is an overlap, particularly in sub-Saharan Africa, of both TB infection and drug-resistant TB. And I guess that's why I work in South Africa, because of the strong overlap between the two. What we've seen, and this kind of talks a little bit about the first talk, is that we were really doing well in terms of TB control, or managing to get a hold of the TB epidemic by various methods, including universal testing and treating of people with TB, but we suffered a little bit of a blip during COVID. And that's, I think that there are lots of theories why this occurred, but one of them is definitely that people stayed away from healthcare. And for the most of 2020 and maybe 2021 as well, and that resulted in delayed diagnosis, and probably some of the mortality we saw in COVID was also TB related. We all, I know that I was going to say I eat, sleep and breathe TB, but maybe not breathe that much. But I'm sure most people in the audience have heard of extensively drug-resistant TB, or XDR TB. And in early 2020, we actually changed the definition. Extensively drug-resistant TB is supposed to represent something that requires special intervention and treatment. In the olden days, and it's weird to say that the olden days were 2019, the definition of extensively drug-resistant TB was TB that was resistant to both rifampicin and INH, our two cornerstones of TB treatment, and also to injectable agents and quinolones. But because the field has moved so far, it's no longer interesting to talk about the injectable agents. So we've redefined extensively drug-resistant TB, and I'd like you to have a look at the slide at the bottom, where we redefined extensively drug-resistant TB as TB that is resistant to fluoroquinolone and one of the other additional Group A drugs. I'm sure you're all rolling your eyes and saying, what on earth is a Group A drug? And I will get to it shortly. But what it is saying is that the Group A drugs, you can guess, are the most effective drugs for drug-resistant TB. So if we've lost more than one of them, we call that extensively drug-resistant TB. How we treat XDR TB is still, I refer to it as the kitchen sink approach. We use just about anything that we can, any still active drugs. But now what I want to talk about is what are these new Group A drugs, or what falls into Group A? The first one, and I think that this was the biggest breakthrough in the treatment of rifampicin-resistant TB, is a drug called bedaquiline. It was first registered by the Food and Drug Administration in December 2012, and very shortly thereafter was registered by our regulatory authority in South Africa. It's a bactericidal drug. It doesn't work very quickly. It's got what we call a poor EBA, or early bactericidal activity, but it has conferred a massive, and I'll show you a slide shortly, mortality benefit for those people who are suffering from drug-resistant TB. We've finally got a phase 3 study done called Stream 2, and this is the excellent drug for the treatment of drug-resistant TB. It is a Group A drug. It's been widely adopted by national TB programs, and I'm proud to say that our South African TB program has used most bedaquiline, and this has shown a huge mortality benefit. It's not registered for children under the age of 6. I think this slide really shows the major difference. What we looked in our program was the difference between people who got bedaquiline and those who didn't. And you can see from very early on, and this is measured in weeks, that the curve split out. So bedaquiline is indeed a life-saving drug. The other 2 new drugs that are registered is one called delaminate. It's not yet approved by the FDA. It seems to be a pretty useful drug to use to protect against resistance, but its access is limited at this stage, and it might change in the next month as more generics are registered. Its access is limited by high cost. And then the final one of the new drugs is a drug called protominate. It's also a nitramidazole. We know nitramidazole is in the form of metronidazole. It was approved by the FDA in 2018 as part of a regimen called BPAL. And this is a huge game changer in the treatment of drug-resistant TB. It is suitable for almost everybody who has not been exposed to these drugs before, including persons infected with HIV. It's not yet shown to be safe in pregnancy in children, and not yet characterized by the WHO. So that was a quick cook's tour of what's been going on in the field of drug-resistant TB. I'm just kind of squashing my last 15 years of work into 5 minutes. But so now how do we go about treating drug-resistant TB? We've got 2 regimens, and this one is the kind of more cumbersome one, and you can see that by the number of words there on the slide. We use a combination of up to 7 drugs, and the drug that's highlighted is ethionamide. Ethionamide is kind of the poor man's INH. It's got an overlapping resistance pattern with INH, but it can be replaced, as we've shown in our South African program, with ethionamide, with linezolid. So again, this is quite complex, stop and starting drugs at various stages, which is difficult both for practitioners as well as for people who have the condition. But then came the major breakthrough. Now the WHO has endorsed the treatment of drug-resistant TB, so that's rifampicin-resistant TB and upwards or downwards, I'm not sure which way you go, with a new short all-oral regimen called BPAL with the addition of moxifloxacin. This is a treatment that is given for 6 months only. There are 23 pills, which might sound a lot. We ask our patients to take 23 pills over a week's period, but that needs to be borne in mind. In about 10 years ago, we were using 23 pills a day. So it's a great reduction. The study that showed it to be originally effective was a study called NIX, and then we did an optimizing of the dose of linezolid, which is the toxic drug, in a study called ZENIX. All this information was collated by the World Health Organization, and we show that even amongst the most difficult to treat forms of TB, we can expect cure rates of 90%. And just in case you're wondering, that's not a spelling mistake. We expect about 90% of our patients to be cured. And this has been shown in clinical trials, which we all know are slightly rarefied beasts because we select our patients very well. But we are now seeing that as we're rolling this particular regimen out in programs, including the South African program, and it's been rolled out in the Philippines and some other Southeast Asian countries. So, how do we prevent rifampicin-resistant TB from occurring in people who are living with HIV? The first thing is that it's almost always a transmitted disease. We used to say it was from people who didn't take their treatment properly, but that's incorrect. It's in fact from people, it's usually transmitted. We need to be able to find both disease and infection early on. And the prophylaxis that we choose to give depends on where the person was exposed. So our various candidate drugs for prevention of rifampicin-resistant TB are INH, ethambutol, levofloxacin. There are many strategies available, but many strategies that have been tried but are still in clinical trials. So to sum up, you might have noticed that I hardly ever made any difference between those who are HIV infected and those who are not. Because in fact, there is no difference between the treatment of rifampicin-resistant TB by HIV status. Of course, in order for people with TB to survive, we need to rapidly initiate antiretroviral therapy. And most of the currently available antiretroviral therapy does not interact with any of the drugs that I've mentioned so far. And the outcomes of these treatment regimens that I've described rival those of drug-sensitive TB. Thank you very much.